Welcome to this MedNexus Explainer. I am so glad you're here today because, wow, do we have a fascinating hematology disorder to look at. We're going to break down the complex mechanics of the blood step by step. If you've ever wondered how your cellular machinery can just go rogue and completely alter the physical properties of your bloodstream, well, you're in exactly the right place. Grab your notes, get comfortable, and let's get right into it. Okay, picture this, a bizarre medical mystery. What if a patient comes to you and their blood is slowly and silently becoming thicker than normal? And no, we are not talking about simple dehydration here. We're talking about a patient having persistent headaches, a really flushed red face, dizzy spells, and a terrifyingly high risk for dangerous blood clots. But wait, here's the absolute strangest clue of the whole shebang. They complain of severe, unbearable itching right after they step out of a hot shower or bath. Why? Well, this is the reality of a primary bone marrow disorder, where the body just pumps out excess red blood cells completely uncontrollably. It's called polycythemia vera. So, what's on the agenda today? We'll hit first, the thick blood syndrome. Second, the JAK2 mutation. Third, symptoms and complications. Fourth, diagnosis and differentials. And finally, we'll wrap up with treatments and exam pearls. All right, kicking things off with part one, the thick blood syndrome. So what exactly is polycythemia vera? It's defined as a chronic myeloproliferative neoplasm. Let's break that down. Myelo refers to the bone marrow, and proliferative means it's rapidly multiplying. The absolute core concept you need to anchor in your brain right now is that this is a primary bone marrow disorder. The marrow is just churning out red blood cells in a totally uncontrolled way. And actually, it doesn't even stop there. It often ramps up the production of white blood cells and platelets too. This massive, unchecked increase in red blood cell production directly leads to a huge spike in blood viscosity. In plain English, the blood becomes way, way too thick. Which brings us to part two, the JAK2 mutation. It all kicks off at step one with a very specific genetic error, the JAK2 mutation. This single mutation triggers step two, which is uncontrolled hemopoiesis. That's just the massive, unchecked creation of blood cells. Now all those extra cells start crowding the bloodstream, leading directly to step three, hyperviscosity. Imagine a highway that normally handles, say, 100 cars, suddenly getting jammed with 10,000 cars. The result is step four, sluggish blood flow. It is literally a traffic jam inside the patient's blood vessels.
And this brilliantly illustrates exactly how the engine gets stuck. You see, the JAK2 mutation triggers the constitutive activation of the JAK-STAT signaling pathway. Now, constitutive is really just a fancy way of saying always turned on. Normally, your bone marrow is polite, right? It waits for growth factor signals before making new blood cells. But with this mutation, the marrow becomes growth factor independent. It doesn't wait for a signal anymore. The accelerator is just permanently mashed to the floor, forcing the production of excess cells day and night.
Moving on to part three, symptoms and dangerous complications. Let's look at the classic clinical features you absolutely need to memorize. First, we've got headache, dizziness, and visual disturbances. Why? Well, because that thick, highly viscous blood causes sluggish microcirculation, which significantly reduces cerebral perfusion. Basically, the brain just isn't getting that smooth, normal blood flow. Next, you're going to see ready cyanosis. That's a distinct red-purple complexion caused by the sheer mass of red blood cells. You'll also often find splenomegaly, an enlarged spleen, because the spleen is actually trying to help out with all this blood cell production, a process called extramedullary hematopoiesis. And then we have aquagenic pruritus. Now, what's really fascinating here is the specific why behind that incredibly bizarre symptom. Aquagenic pruritus is severe itching after contact with warm water, like taking a hot shower. Why does this happen? Well, the hot water triggers an abnormally massive release of histamine from the elevated numbers of cells, like basophils and mast cells, in the skin. The result? Intense, severe itching. Let me tell you, if you ever hear the phrase itching after a hot bath in a clinical scenario, polycythemia vera needs to immediately jump to the absolute front of your mind.
But as uncomfortable as the itching is, it isn't what kills the patient. The most dangerous complication, unequivocally, is thrombosis. That thick, sludgy blood severely increases the risk of massive, lethal blood clots.
So the crucial point here is understanding the widespread damage these clots can actually cause. Thrombosis can lead to a stroke, a myocardial infarction, deep vein thrombosis, and Budd-Chiari syndrome, which is an occlusion of the hepatic veins. But take a close look at the last two complications. Due to the massive turnover and breakdown of so many cells, uric acid levels spike. That causes hyperuricemia and gout. And incredibly, despite this massive risk of clotting, patients can also experience paradoxical hemorrhage. How? Because even though there are tons of platelets floating around, they're often dysfunctional, leading to dangerous bleeding right alongside those massive thrombosis risks. Crazy, right? All right, part 4, diagnosis and differentials. Let's lock down the highly important diagnostic triad. First, you're going to find an increased hematocrit and a hemoglobin, which obviously reflects that huge mass of red blood cells. Second, and this is critical, erythropoietin, or EPO, is low. The body knows there are way too many red blood cells, so the kidneys literally shut off the signal to make more. Third, the patient will test positive for that JAK2 mutation. Oh, and additionally, a bone marrow biopsy would show hypercellularity and panmyelosis, meaning all the different cell lines in the marrow are overgrown. Now, here is an absolute must-know exam pearl, separating primary from secondary polycythemia. In primary polycythemia vera, the problem is bone marrow-driven. Because the marrow is making cells completely on its own, the body's EPO levels are suppressed, so they'll be low or normal. But in secondary polycythemia, the condition is hypoxia-driven. Think of a patient with severe lung disease, or maybe someone living at a super high altitude. Their body is starved for oxygen, so their kidneys pump out massive amounts of EPO to force the creation of more red blood cells. So the rule of thumb? High EPO means secondary. Low EPO points directly to primary PV. And finally, part 5, treatments and exam pearls. The primary treatment goals here are to rapidly reduce the blood viscosity and prevent those lethal blood clots. Number 1, phlebotomy. This is your first-line treatment. It is literally the therapeutic removal of excess blood to lower the hematocrit and instantly reduce viscosity. Basically, taking the extra cars off the highway. Number 2, low-dose aspirin. Absolutely crucial for preventing platelet aggregation and warding off thrombosis. And number 3, cytoreductive therapy. For our higher-risk patients, we use drugs like hydroxyurea to actively suppress the bone marrow's overproduction. Let's move to a rapid review sequence to really lock this information into your memory. Equation 1. Uncontrolled increased production of red blood cells leads directly to increased blood viscosity. Equation 2. Always remember the trigger. The JAK2 mutation is the ultimate root cause that flips the switch, leading to massive, unprompted, and increased hematopoiesis. And finally, equation 3. Increased viscosity leads directly to a massive increase in thrombosis risk. Never, ever forget that this is the primary, most dangerous, and life-threatening consequence of the disease. So polycythemia vera is a classic hematology disorder where uncontrolled bone marrow activity turns the blood into sludge, putting the patient in grave danger. Early recognition is absolutely crucial because, as we saw, timely treatment like phlebotomy can significantly reduce complications and improve survival. But I want to leave you with a provocative question to chew on. How will understanding the mechanics of polycythemia vera shape your view of all thrombotic risk mechanisms and other myeloproliferative neoplasms? Keep that question in mind as you apply this knowledge moving forward. If you found this explainer helpful, please share it and let us know which hematology topic we should cover next. Keep learning, keep asking questions, and I'll catch you next time.